Now, my task is to discuss with you strategies of immunotherapy. And I think, first of all, before we can actually address the options, we should have a look at how cancer, and especially myeloma, is trying to escape the immune surveillance. So what you can see here is the cancer immunity cycle. So first of all, the tumor cell is releasing antigen. The antigen is taken up by antigen-presenting cells, mainly dendritic cells. Then there is a priming and activation of T cells. T cells are then being activated. They move to the tumor. They try to infiltrate in the tumor, and then they try to kill the tumor. And there are two areas where the tumor is trying to escape this kind of immune surveillance. And one of these strategies is the so-called non-inflamed tumor phenotype. And this non-inflamed tumor phenotype means that the microenvironment of the tumor, with high expression of vascular markers, with very low inflammation and low chemokine expression, prevents the cytotoxic T cells to infiltrate into the tumor. The second strategy the tumor is developing is the so-called inflamed tumor phenotype. So in this case, the cytotoxic T cells can infiltrate in the tumor because there's high levels of innate immune signals, high chemokine expression, but then the tumor cell itself, by expressing inhibitory receptors or by accumulating suppressive cells like Tregs, Bregs, or MDSCs, is kind of inhibiting the function of these anti-tumor T cells. So still the most effective form of immunotherapy is allogeneic stem cell transplantation. And why does it work? First of all, you have functional T cells from a normal healthy donor. You have in the tumor inflammation because you do use some conditioning regimens, and you induce a cytokine release syndrome, which allows the donor T cells to traffic to the tumor, and the residual tumor cells are expressing new antigens that the immune cells haven't seen, so there is a transplant versus tumor reaction, but there is also a patient-specific antigen-directed reaction which induces graft versus host disease. So here you see one of these examples in which a patient who was really refractory to all kinds of treatment, including autologous stem cell transplantation, responded to the allo and remained in complete remission. And we have seen in patients, even with high-risk disease, that quite a high proportion of patients is actually remaining in remission following allogeneic stem cell transplantation. We still have some transplant-related mortality, but the main problem is the high relapse rate. So one of the ideas to actually make immunotherapy to work in multiple myeloma is to learn from allogeneic stem cell transplantation as kind of separating GVHD and GVL. And the idea is to select immune effector cells that can mediate graft versus myeloma effect, but do not induce graft versus host disease, and finally to do some cellular therapy without doing an allografting. And here you see one of the cells that can be used to induce graft versus myeloma effect without actually inducing acute graft versus host disease, and that's our gamma delta T cells. These are data that looked at the reconstitution of gamma delta T cells after allogeneic stem cell transplantation, and you can clearly see that patients that have a rapid reconstitution when compared to the ones with a slow reconstitution of gamma delta T cells have a much better event-free survival and a much better overall survival, indicating a better tumor control and a better infection control without actually an increase in acute graft versus host disease. So one of the ideas that we had was to use these gamma delta T cells to treat patients with multiple myeloma. And you can see that you can activate and expand these gamma delta T cells very nicely using aminobisphosphonate and IL-2. And we developed a protocol in which we did a lymphodepletion in these patients using fludarabine and cyclophosphamide. So you can see that in these patients the lymphocyte count is going down. Then we infused gamma delta T cells from a haploidentical donor. And these cells were then exposed to aminobisphosphonate and IL-2 that was given to the patient. You can see that here are the haploidentical gamma delta T cells that are expanding, and they are persisting for about 2 to 3 weeks. Then the endogenous immune system is recovering from the lymphodepleting therapy, and these haploidentical cells are rejected. But that was sufficient to actually get this patient who was in a far advanced progression into complete remission, and the patient remained in complete remission for 9 months. But we have the main problem with all forms of immunotherapy that there are a lot of immune escape mechanisms of multiple myeloma. And I already explained the inflamed tumor phenotype, when suppressive cells and inhibitory signals are kind of inhibiting the anti-myeloma directed T cells. So what can we do about this? And here is the strategy of the checkpoint blockade. Checkpoint blockade means that we are not attacking the tumor cell, but we're trying to modify the immune cell, because the tumor and also the T cell itself, by inhibitory molecules, are kind of making the myeloma-specific T cells dysfunctional, and you can overcome this by actually giving these checkpoint blockers. And you have seen this slide already before, that myeloma cells express PD-L1, so inducing this dysfunctionality in T cells. And you can also see here that the T cells that are kind of in the tumor microenvironment of a myeloma are increasingly expressing PD-1, especially in the more advanced myeloma patients. So good reasons to actually use these checkpoint blockers in multiple myeloma. And I guess that you have seen this slide also before. This patient who was extremely heavily pretreated with all the agents that you can imagine without showing any response, and then being treated with lenalidomide, dexamethasone, and the checkpoint blocker, and suddenly the patient achieved a complete remission and remained in this complete remission. And this response in very advanced myeloma probably is something that we also have seen in other tumors, like in metastatic melanoma, when especially very advanced patients with high genetic complexity and high neoepitope load are the ones that respond the best to immunocheckpoint blockers. The other strategy, and that's one of the problems that we face if we do immunotherapy for cancer and also for myeloma, is that in patients and also after allogeneic stem cell transplantation, there is a very low frequency of myeloma reactive T cells. And without allo, there is a low inflammation in the myeloma microenvironment. So what we have to do is we have to increase the frequency of the myeloma reactive T cells, and we have to increase the local inflammation. And there are actually two strategies to do this. One strategy is to use one strategy is to use bispecific antibodies, and the other one to use CAR T cells. So what about bispecific antibodies? Bispecific antibodies are very small molecules that have two binding sites. One binding site which is directed against the T cell, and one binding site that is directed against the tumor cell. And the idea of these bispecific antibodies is that in patients that have a low number of tumor-specific T cells, you redirect T cells that are directed against viruses, which are common and frequent in patients with multiple myeloma, that you redirect these T cells, and with the bispecific antibody, redirect these T cells to the tumor cell, and by this you can actually induce lysis of the tumor cell. And this has been very effective in the setting of CD19 positive tumor cells. Here you can see that after treatment with a bispecific antibody, you get a vast expansion of effector memory cells. So these are all cells that can mediate anti-tumor reactivity, and that this expansion of these tumor-reactive T cells associated with some form of cytokine release syndrome, so you have the local inflammation to get the T cells into the tumor, that this can be very effective, like here in patients with indolent lymphomas who have been heavily pretreated, and we have seen patients now, more than 50% of these patients are now in ongoing complete remission just with a monotherapy with this monoclonal antibody. And which was even harder to do is in patients with refractory relapsed ALL, and even in this patient cohort, about a third of patients are getting into complete remission and remaining in complete remission after treatment with these bispecific antibodies. So can this strategy applied also to multiple myeloma? We believe yes, and there is a bispecific antibody of the BiTE format, which is binding to BCMA and to the T cell, so it's a kind of a myeloma-specific BiTE, was nicely tested in vitro and also in a xenograft model, and showed high myeloma activity. BCMA is an interesting target to be used for these bispecific antibodies, but it's because it's broadly expressed on the myeloma cells. So most of the patients that have been analyzed show high expression of BCMA. It's also expressed on normal tissues and normal plasma cells. So the idea is by redirecting the T cells, again, it's mainly virus-specific T cells, to this BCMA antigen to actually induce lysis of the myeloma cells. And we have, in a very nice French-German collaboration, a phase 1/2 trial going on for patients with advanced multiple myeloma with this BCMA BiTE. Another development is the so-called trispecific antibody, because you have seen that in most of the tumor cells, the target antigen is not exclusively expressed on the tumor cell. And it's expressed also on normal cells, and that actually means that these normal cells are also being targeted by these T cells that are redirected, and this induces some toxicity. So the idea of the trispecific antibodies is to actually target not one, but two antigens on the tumor cell, and the idea with this trispecific antibody is to target two antigens that really make the attack on the myeloma cell highly specific, like using CD38 and CD138. The other development, and Aaron has already alluded to this, is the CAR T-cell therapy that was published in the New England Journal in Science, and probably even more important than New York Times. And they showed that this young child with ALL that was completely refractory to all forms of treatment went into complete remission after CAR T-cell treatment, which now has kind of created a huge waiting list in centers mainly in the US that offer CAR T-cell therapy, and has induced industries partnerships involving several billions of US dollars that are spent on the development of the CAR T-cell program. Unfortunately, in Europe, we have up to now quite little activity in CAR T-cells. So again, how do CAR T-cells work? It's about the same principle as with the bispecific antibodies. We are addressing mainly effector memory or central memory T-cells, so mainly virus-specific T-cells that are getting an additional immune receptor, which is composed of the antigen binding domain of an antibody, and then has a transmembranous and a signaling domain of a T-cell receptor. And this allows the T-cell that was originally, for example, made specific for EBV, now also attack a tumor cell. And for myeloma, different antigens are going to be explored, like BCMA, CD38, CD44V6, SLAMF7, and CD138. And the advantage of the CAR T-cell program is that you can actually include in your genetic modified cells additional functions like drugs, so you can make this T-cell in addition to secrete certain chemokines, which will attract in addition immune cells to the tumor, or include anti-PD-1 strategies, so you can overcome some forms of anti-tumor tumor escape, immune escape phenomenons, as we have seen also in multiple myeloma. And there have been some patients, and Aaron has already alluded to this, being treated with the CAR T-cells directed against multiple myeloma. The strategy again is using a lymphodepleting treatment with cyclophosphamide fludarabine, then infusing the CAR T-cells in increasing dosages. And it has been shown that, for example, with these CAR BCMA-directed T-cells, about 4 out of 12 patients were responding with one very nice response. And at the ASH presentation, the authors alluded to this one patient who really developed an extremely severe cytokine release syndrome. So again, local inflammation, which allows the T-cell to infiltrate the tumor. The patient was on intensive care unit for several days, had a very prolonged marrow aplasia, but then recovered and achieved a stringent complete remission following this CAR T-cell program. We are working on another strategy, so we are looking at the SLAMF7 directed CAR T-cells, which is the epitope of the elotuzumab antibody. And you can see that these CAR T-cells that are expressing these SLAMF7 directed CAR can nicely kill myeloma cells, that they nicely do a cytokine production, that they proliferate when you expose them to myeloma cells, and that at least in the mouse model we see a complete clearance of the myeloma cells. So the myeloma cells are here in blue. You see the growth of the myeloma cells in the mice that are not receiving the CAR T cells, whereas the mice that receive the CAR T cells completely clear the myeloma cells, here indicated in blue. And our strategy is to a kind of a different strategy. So we don't use bulk T cells, but we use a fixed combination of CD4 and CD8 positive cells carrying the CAR T cell, which allows to reduce the number of T cells to optimize the in vivo expansion, which will probably reduce the risk of a cytokine release syndrome. And we use a non-viral transduction system, which will help us to reduce the cost and maybe also be more regulator friendly when using lentiviral or retroviral transduction systems. So I hope I could show you some of the strategies that are in the clinic or are coming into the clinic with immunotherapy for multiple myeloma. And I think we're going to see a dramatic change in the treatment strategies for myeloma because of these evolving immunotherapeutic strategies. And with this, I would like to thank you all for your attention.